Day. Thank you all for joining us today. We have a fantastic program today with our guest professor, Dr. Ganesh Shankar, an MD, PhD, neurosurgeon from Mass General, and I'm going to introduce him more specifically later when he's going to give his lecture. Ben, is he live?
He's running a few minutes.
He's running a couple of minutes behind, so I'm going to introduce him again. But he was so kind to, based on our request, talk about something that we really overlook a lot, and that's CSF, the CSF space, and dural integrity, and what can happen when we have dural problems. So we're really looking forward to his presentation later and his input in our cases. Before we get started, I wanted to just point out we have our 8th annual, time flies, truly a trauma summit, December 2nd and 3rd, co-chaired by Drs. Andrew Daly from Utah and Dr. Rick Sasso from Indiana, who will be here. We have a true all-star faculty, and as you know, every year we change the topics around and we hit hard on a variety of things. This year we'll have a visiting professor from Germany, Dr. Thomas Schildhauer. He's the chairman of the University of Bochum, and he's one of the godfathers of lumbopelvic fixation. In fact, he's the one who's first published on this in the 90s. So we're really looking forward to having him here in person to show us how to do lumbopelvic fixation and to look at the latest advancements. We also will focus on osteoporotic fractures, and we have Professor Schnake from Germany, also a well-known entity in the European world who has really advanced our knowledge of osteoporotic fixation. Again, that's December 2nd and 3rd. Please join us. As always, it's free, it's super high quality, and great speakers with entertaining debates from all over the country. We'll have some young and some seasoned professors speaking this. So I really am excited about this and would love to have you join us. Now to today's topic. Again, we're going to focus on the fluid that surrounds our neural elements, the cerebrospinal fluid, and its containment structures, the dural membranes. And to kind of warm us up for Dr. Shankar's talk about what can happen when you have chronic CSF leaks, we thought we'd have a couple of case presentations. And I think first is Dr. Jimmy Hicks. So I always say Hines. I have a good friend named Jimmy Hines. I have to apologize. Jimmy Hicks from Alabama originally. And he'll be followed by a brief overview by Dr. Abe Schlatter, who kind of put together a couple of things in terms of state-of-the-art repairs. So Dr. Hicks, take the podium and show us what you got.
Let's pull it up here. All right, we have a very interesting case. A lot of words on this slide. We'll get through it.
I thought we'd agreed you'd make large font slides.
Yes, it easily read from the back of the room. So 56-year-old female, thoracic myelopathy secondary to OPLL. She undergoes a large posterior segment instrumentation, T1 to 12. She had Lamies from 1 to 10. There were 2 small punctate dural tears intraoperatively, secondary to her disease process, possibly fistular with the OPLL. These were repaired. Postoperatively, she was noted to have full strength immediately post-op. 3 days later, she is noted to have some bilateral lower extremity weakness. I'll show her examination on the next slide. Immediate imaging was unimpressive. She started on NASCAS-2 protocol overnight, which is our steroid protocol for spinal cord injury and presumed reperfusion injury in her case. Re-examination showed hyperreflexia to bilateral lowers. And she undergoes IND revision Lamies, T4 to 12, removal of some dorsal bone graft, and she completed another 23 hours of that NASCAS-2. 10 days later, we are notified that she's having a thoracic sensory deficit, and again, bilateral lower extremity weakness, and there's a fluid accumulation noted on CT. This is noted to be a pseudomeningocele, appreciated during emergent decompression. That was done within about 6 hours of her onset of these new symptoms. And she was decompressed. And at that time, there was fat graft augmentation as well as the Duramatrix augmentation at that second revision there. During her stay, her strength waxed and waned, mostly over a progressing level of strength. However, did have a significant drop foot on discharge. This was her initial decline, an examination, again, bilateral lower extremities affected. And then we were doing the reperfusion, secondary to the reperfusion injury concern on steroids during the interval examinations. She did develop hyperreflexia. This is her original imaging showing her OPLL, and apologize for the grainy axial image of her thoracic spine, but you can still appreciate the amount of stenosis she has at that level. Onward here, these are post-operative imaging studies trying to show some compressive etiology at the superior end of the construct. And then these are axial cuts at the superior end of the construct after the first surgery, leading to the initial revision for her new lower extremity weakness and hyperreflexia. And then kind of the best cut I could see. This is her 10 days into rehab, this compressive pseudomeningocele. Obviously, a much larger fluid accumulation. You can see dorsal to the spinal column compared to her other postoperative CTs.
Shall we stop there?
Sure.
Well, thank you for the novel introduction.
Here we go.
Quite wordy, but the pictures tell a lot. So if you go back to the OPLL one, good morning, Ganesh. Dr. Shankar, thank you for joining us from Boston.
Good morning. Thank you for having me.
Audio from you or a visual? Yeah, there you are. Good morning. Thank you for being here.
It's truly my pleasure. Thanks for having me.
So we'll have 4 cases, actually 3 cases and 1 brief overview. And as always, we want our visiting professor to key in and tee off. OPLL is something that afflicts a lot of our patients here. We have a large Pacific Rim population here, but it doesn't just affect them. Tell us what, in your view, happens in OPLL to this proud, amazing, resilient dura mater. Why do they get so frail? What's the histomorphologic process that takes place?
Was that sorry, that was directed at me?
Yeah. So Ganesh, why does the dura in OPLL patients become so flimsy or just ceases to exist as its own entity?
Yeah. There's this is, and even when we see OPLL in the cervical spine, I'm very hesitant to go with an anterior approach because I do feel that oftentimes when we see OPLL, there is an implied calcification and very tight adherence to the dura. And so in the few times that I have addressed OPLL anteriorly, I will have at least a partial thickness dural dehiscence, if not a full thickness dehiscence, and it can become a nightmare. And so I think it's very similar here. I've also seen instances where a very rare case of, but reported in the literature, of dural calcifications that can happen circumferentially, and those can be notoriously difficult to treat as well. But I do think that with OPLL, it's on a continuum where the dural lining and the cell layers do end up either getting adherent to the pathology or become one of the pathology. And to resect it, it would require basically an expectation that there will be a partial thickness dural dehiscence. The only other thing I'll say in this case that's very unique with the OPLL is that it is at the apex of the thoracic kyphosis. It's at the watershed territory of the spinal cord perfusion territories. And so even with a posterior decompression, I would just be curious to see, even on myelogram, since the MRI can be uninterpretable with all the hardware, just if the cord did get enough of a decompression with the posterior decompression alone, or if there's still a draping of the cord over that ventral pathology.
Great answers, and yeah, this is just a phenomenon. And our colleague who did the surgery, I think, shared the same concerns that you had voiced, and that's our colleague did not want to go from anterior. He wanted to do everything posterior and stabilize the patient because it was the apex of the kyphosis, so he did not want to worsen that. But nonetheless, there were posterolateral dural deficiencies, probably in that area where the hyperostosis occurred, that inflammatory hyperostosis. So very frustrating case. Now, what Dr. Hicks demonstrated here is a secondary neurologic deterioration, and the patient developed a substantial pseudomeningocele. Can you explain to a simple orthopedic spine surgeon like me how it can be that a pseudomeningocele can cause secondary cord compression given the various hydrostatic pressures? How can we explain that?
I was hoping you wouldn't ask me that question because it's obviously something that we struggle with as well. Here in Boston in neuro, it's obviously a very challenging postoperative complication and phenomenon. The only way I can put it together is that perhaps there's some kind of ball valve phenomenon where the CSF gets trapped on the other side of either the fat graft or the dural onlay, and then there's actually a pressure gradient that develops. And just to reiterate, especially with the preoperative history, this is a very sick spinal cord, and so even the slightest bit of manipulation, either intraoperatively or postoperatively with changes in blood pressure or perfusion pressure, because now there is even a slight pressure gradient on the epidural surface from a pseudomeningocele that might be ball valving and cannot communicate effectively with the thecal sac, intradural thecal sac. It may be just enough to tip over this patient into a more symptomatic state of thoracic myelopathy.
Then I have one more question for you, and we're really honored to have Dr. Zorika Buza join us also. She gave a great talk about bone physiology, and both of you share a great, you, Dr. Shankar, and Dr. Buza share a great knowledge of bone graft physiology and bone physiology. The colleague in question put bone graft onto the dura, stating that it's a viable tissue membrane for bone cell attachment. And I do acknowledge that this was something that historically was done. I'm an older guy, obviously, and I saw in neuromuscular patients the dural sac being coated with bone graft. What do you think about that practice, putting morselized bone graft on the dorsal dura to kind of get a bone tube reestablished? Does it make sense to you, or what are your thoughts? Wait, we lost your audio, Ganesh. Sorry, we lost your audio.
Yeah,
I'm not
sorry,
sure.
can you hear me now?
Yes.
Okay, that by applying the bone graft, it would basically recreate the dorsal element of the spinal canal.
Yeah, exactly.
With some kind of bridging of bone.
Morselized bone graft. Just put morselized bone graft on the dorsal dura after the hardware was put in. Do you think that's a sensible thing to do? I mean, I know historically it was done, but I was always told, do not put bone graft onto the dura. And yes, it pulsates. Yes, it can kind of remodel the bone as it heals. And it's a viable biostructure. It's an amazing tissue. But does that make sense to you or not so?
I don't know. I'd have to look into that a little bit more. I think it's obviously a very interesting concept and idea in bone physiology and the relationship with dura. The one extrapolation that I could make is with laminoplasty. And in those cases, if the bone is hinged and held static in that location and not made, and it's not exposed to the pulsatility of the dura, in some cases, we can actually see that there's a bridging of bone that occurs between the fractured portion of the lamina and the lateral mass. And in many cases where I do intradural work, such as the ones that I'll show, I'll actually place, if it's not a compressive bony pathology, I'll take the lamina off en bloc and I'll actually restore and reconstruct the dorsal elements by laminoplasty with the hope that it actually restores some amount of just overall compliance of the thecal sac and restores as much of that normal physiology.
I love that term, compliance of the thecal sac. That's a great term, great concept. Practical advice, as you know, I'm still a spring of unresolved questions. So one more question for this case, if I may, to you. So here we have a large posterior thoracic exposure, decompression, and done atraumatically and posterior instrumentation. And there are just 2 or 3 areas of posterolateral dura that are, or lateral dura that are just flimsy. There's nothing there. It's like a little bit arachnoid, and there's CSF flowing out. How should the surgeon in question, in your opinion, with all your knowledge, repair this problem?
Yeah, it all depends on, first of all, it's just that this is very challenging, and it's, frankly, it can be annoying when it happens intraoperatively because everything can be going very well, and then all of a sudden there's this dehiscence. I think it all hinges on 2 things. One is, what is the size of the breach? And the second is, where is it relative to our surgical field and the decompression? The basic tenets that I follow are, number one, expose the full margins of the dural breach, and so that could require an expansion of the laminotomy or laminectomy. It could also require increasing the lateral exposure through either a full facet resection or even a rib resection if it's very lateral, and we need to get access to the full margin of the dural tear. And then it becomes a question of how to repair that. And it could either be with a primary closure, but I often find in these types of bony pathologies where there's a rather large breach of dura, it can be very challenging and often an ill-fated attempt to try to get a primary closure with either neurolons or prolines, because that'll just keep tearing. So it requires some element of a graft, either a fat graft, or some kind of dural substitute. Personally, I like bovine pericardium, or if the patient has good quality fascia, harvesting some fascia can be good as well. The only other ideas I would have, especially in a patient where I'm not confident with the quality of the dural closure, would be to consider placing a lumbar drain if the patient continues to leak. But that has its own risks of complications as well in terms of creating subdural hematomas. And the last is to try to divert the potential pseudomeningocele that's developing with a drain that is to gravity, and like a subfascial drain that's just to gravity and not to suction.
Great. No, this is a great bandwidth. And again, assume that in this patient, there was no way to repair this. I totally believe our colleague has said this can't fit, this can't be made. So here we are now. If we don't put a lumbar drain in, do you allow a patient who has just a subfascial overflow drain, if you so will, to mobilize, or do they stay down at bed rest? So address, if you will, the old adage of keeping the patient, quote, at bed rest for a period X, 24 hours, whatever, 72 hours, etc. Is that sensible, or is that fiction?
Yeah, I think it's really dependent on the patient. There's a recent paper that looked at this very question of not keeping people in bed after an incidental durotomy versus mobilizing people in a delayed fashion. And it actually turned out that is a very recent paper in the last couple of months in our literature, which is that it actually was to the patient's advantage to mobilize them sooner than keeping them bedbound. And so I think but I still want to just provide the caveat that it's really dependent on the confidence that we have in terms of how much of a dural closure we have. If it's, just a little bit of drainage that we see with a Valsalva, that's one thing where maybe the patient can still mobilize and we keep a close eye on for postural headaches and put them back in bed if they develop that. But otherwise, I try to mobilize them right away. That's a different entity than, let's say, patients who have some kind of big sacral tumor where they've been previously radiated, and then we do some kind of extensive resection with multiple dural dehiscences where we have very low confidence in the CSF, in the containment of the CSF space. And in those cases, we would be more hesitant to get them up right away and maybe a prolonged course of bed rest, at least a couple of days.
Great answers. Let's move ahead with the case then. So Dr. Hicks, what happened with the patient? So we took the patient back. We found a large pseudomeningocele. We found morcellized bone graft on the dura that we carefully removed. What, in your review of this case, actually caused the neural deterioration? Was it the bone graft caking in? Was it CSF, that pseudomeningocele with a ball valve effect?
Yeah. I think bottom line is we'll never really know, but the MRI prior to the first revision shows compressive etiology, dorsal to the column. So I think that was worth going in to address. And then the pseudomeningeal we know can be compressive, and even many months or even years after a dural tear of pseudomeningeal can develop and compress. So I think it was addressed appropriately. So
now, Rod, I used fat graft to repair this. We did this on a weekend rather urgently because she declined. We went far more lateral. There's nothing repairable. I mean, I have no problems with microsurgical technique repairing very small and complex dural membranes, but I've put fat graft and I sewed fat graft on there.
Yeah.
And I think our mutual mentor, Dr. John Jane, always said, the fat loves the dura, right? So what do you use in this setting and why? And what do you think about Ganesh's thought of using fascia?
I mean, I think I like lumbar drains. I think, when the dura is calcified and thin, in this case, it's pretty hard to get a primary closure. I like Surgicel, fat. I mean, anything you can do to kind of prevent it from pouring out. But I think, given that you have this after surgery, I probably would do lumbar drain.
What did we do and how did the patient do?
So in terms of surgical management, the second revision was dural enhancement of width of the fat graft, additional fat graft to seal and dura matrix. She didn't have any further revision after the second case, so she did fine.
Okay, so she improved again, and again, she liked the fat in this case, not the fascia. Dr. Boozer, Zorica. Good morning to New York. Zorica, are you live?
Yes, good morning.
Thank you for joining us. This is fantastic. Two of my favorite people, Dr. Shankar and Dr. Boozer, together. So there are a lot of companies that inundate us now with biomembranes, cool stuff with embryonic cells in it and this and that. And the other day I was told this is actually the best stuff for complex, large dural reconstructions. What do you think just in general of these amniotic tissues? And maybe Abe, can you take the podium? What do you think about this jump into these amniotic membranes that have all sorts of cool cells and quote stuff in them?
Yeah, well, they've been used in various fields outside of spine and ortho. And what I've seen recently is, I think when it comes to spine, is preventing with Lammy's adhesions. And I guess that's the plan, to use them, given that they have all the cells and growth factors. But again, just focusing on our field, I don't think we have enough evidence yet. And we are actually looking at the study at the moment, what's the role and how much amniotic tissues help. They've been used a lot in wound healing, but for spine, I don't think we know much. It's the same. I can relate that to other graft materials in spine, where they have all components, but yet we don't know if they help us fuse or not.
Ganesh, does it make sense? Thank you, Zorica. And please, as a basic scientist, whenever we say something questionable, please speak up, okay? So Ganesh, does it make sense to have any anti-scarring agents for dura? This was a huge deal. And I know I was at UW when a unnamed faculty member had a successful company with FDA-approved anti-scarring gels. So this was a big deal in the 90s and early 2000s. And then it just seemingly vanished. Now we have some anti-adhesion membranes. What do you think about this as a physician, surgeon who also has a great basic sciences background? Does that make sense?
I want to just provide an anecdote first, and then I'll answer the question. So when I was a fellow, Doug Orr at Cleveland Clinic, one of his questions that he would ask us is, what is the rate of a durotomy in a revision PSO for deformity? And we'd all guess, like 50%, 70%, thinking that we're being honest. And he would tell us 200%. And he said, it's because you always get at least 2 durotomies in these cases because it's a revision. And, obviously we all struggle. Maybe not in Seattle. Okay.
me
But,
turn that-
you know,
Yeah, go ahead.
I was just going to say, we all struggle with scar tissue in revision cases, and it would be great if there was some kind of magic bullet that would give us no scar, but still allow for healing of the wound tissues, of the tissue planes that we've created. Because in many ways, scarring is actually part of the body's response to either the injury that we've created, or to basically to solidify fusion constructs. It's the same kind of inflammatory cascade that we need. And so by inhibiting scarring, I do wonder if we're actually working against ourselves in terms of what we're trying to actually achieve in the human body. So for example, something as rudimentary as a disc herniation that has created obviously some kind of spontaneous tear in the annulus. We take out the fragment, but we know that patient is at risk for reherniation, presumably through that annulotomy that the patient already had to begin with. And what we're waiting for is for that annulotomy to seal up and fibrose. And so if we block that by placing anti-scarring agents, I do worry that we actually prevent the body from its natural healing response, which is what we depend on in the postoperative course.
Great. So I asked Dr. Schlaudraff to put together his opinion. He's a senior neurosurgical resident fellow from Penn State. He is going to go into great practice in Idaho, and I asked him just to do an impartial review of what we should do for dural repairs. And we have nobody less than Dr. Shankar here to critique what you came up with.
Yeah, great topic.
And just to preface that, so you have one surgeon on the right side of the aisle who is a glue applier. And on the left side of the aisle, you have Dr. Oskuian, who is a non-gluer, who basically believes, he's an anti-gluer. So, and Dr. Shankar just texted me in the chat room. He does use tissual fibrin glue. So let's see what you came up with in your independent analysis.
Yeah, just using the data. So when we're talking about dural tears, there's a lot of types of dural tear. Not every dural tear is made the same. So you can have intentional, which I think are the best types. If you're removing a spinal cord tumor, tethering a spinal cord, something along those lines, versus unintentional interruptive dural tear. You can have arachnoid, which is intact, with just a little bleb poking out through a small dural tear. Or you can have a frank CSF leak. They can be small, they can become large, they can be linear, they can be jagged, complex, spiderweb-like. They can be midline or lateral over the nerve root, axilla, and then some can be ventral. And all those have to be attacked very, very differently. So there's a lot of tools available that I've seen over the last 7 years, and I've unfortunately had the pleasure to use. So primary repair, I think, is the gold standard, the classic. You can use one of the hydrogels that are available, or a fibrin glue product to augment your closure, to assist with it. You can use a patch graft with a lot of different types of patch grafts commercially available, either natural or produced commercially. They can be suturable or non-suturable, depending on what they are. You can also use the patient's own tissue with either a fat graft or a muscle patch. You can also harvest fascia, like we talked about. You can do CSF diversion in the form of a lumbar drain, or I guess a ventriculostomy, but lumbar drain is more reasonable, more readily used. And then another thought is early versus delayed mobilization. Should you get patients up right away, or should you lay them flat for 24 hours or longer? Blood patches, and then again, I think a good solid fascial closure and skin closure is important with these. So primary repair. What can you possibly use? 4O Neurolon is what I use a lot in residency. Here we use more prolines, and we started using more prolines back towards the end of my residency, which I think is actually a little softer, a little less harsh in the tissues. The Neurolon can be braided, and it can kind of tear and make larger openings when you throw a stitch, whereas prolines are a little smoother and less likely to tear open stitches and have leaks through where you actually have thrown your stitches. There's literature out there comparing running locked versus interrupted. I've seen both here. Data says there's no difference with CSF leak rates post-op, whether you use interrupted stitches or whether you use running lock stitches. Some studies that show that sometimes you can't do primary repair if you have a ventral dural repair, which is a dural tear, which is hard to get around to. Sometimes you can use titanium clips and just use clips to close the tears when you can't suture. And that's a good alternative as well. The addition of sealants, there's some different sealants that are out there from different companies. Some on-label, some off-label for usage on dura for closures of CSF leaks. The big two ones are synthetic polyethylene glycol versus biologic fibrin and thrombin products. There was one calf spine model showed that these can improve the strength of a primary repair when used in addition to sutures. However, there are multiple reasonably done systematic reviews looking at all the available literature of whether or not sealants actually make a difference on CSF leaks, and all of them show that there is no difference whether or not you use sealants versus no sealants, which I thought was kind of surprising. Another thing to think about too is that some of the sealants, like the polyethylene glycol ones, they can expand sometimes up to 2 times their size and can result in inadvertent stenosis afterwards. Patches. There's a lot of patches out there, different types of patches, the patient's patches or commercial available patches. You can use autograft muscle fat fascia to assist in closure of holes which are particularly too large to close primarily. So you can suture in a suturable fascial graft, or you can get a suturable patch graft, whether it's commercially manufactured or if it's bovine or different type of material. All those can be very effective with assisting in CSF leak closure. CSF diversion. Neurosurgeons probably do this more than orthopedic surgeons, but lumbar drains can be placed to help take CSF away from where the dural tear is and to decrease the CSF pressure across the tear and hopefully allow less CSF to egress so that it can heal better. One thing to think about if you're doing lumbar drains is to get one that has automatic cutoff like a limitor. That's when we start doing residency. We had some bad events happen where patients went down to get an MRI, let's say, and got left open and they drained off 100 or more cc's. So limitor is a nice valve that cuts off, depending on what type you have, after 20 cc's, so that if a patient's on the floor and gets left open, they don't have a serious complication from that. So something to think about when you're using lumbar drains. Unfortunately, pseudomeningeals can be temperamental and they don't recover from drains. I have seen sometimes shunts have to be put in, lumboperitoneal shunts for severe CSF leaks. That's one thing that possibly could have to do. I've only seen that once though, luckily. Mobilization. Should we get people up right away? Or should we keep them down for 24 hours, 48 hours, 72 hours, or longer? There's multiple studies out there that have looked at this, particularly if you have a good CSF leak closure with a good primary or secondary repair with other adjuncts, that early mobilization is actually better compared to delayed mobilization. There's no difference in leak rates, and the complication profile is actually lower by getting people up right away and not getting the complications of putting people on bed rest for sometimes several days. Other techniques they can use to assist in repairs, there's always blood patches, especially if it's a small little punctate tear after endoscopic or something more minimally invasive. A good watertight closure is key, having a meticulous fascial closure and superficial closure. And sometimes you can use a subfascial drain instead of a lumbar drain to kind of offload the wound while it heals to allow it to have a nice solid closure.
So great, thank you. In your institution, Abe, a great nationally renowned neurosurgery program, did you list durotomies as a complication or not?
Yeah.
So they were listed as a complication.
Unintentional dural tear.
Yeah.
Yeah.
So Dr. Shankar, in your institution, do you list the unintended durotomies as a complication? I know at Mass General you have a very robust quality program. Is that a complication or not?
It's not. we don't list it at our usual MMI conferences. It's not reported as a part of our standard QA process.
And why is that? If I may harp on that, I'm not being righteous, but I just want to understand where and what, because we've had a lot of, going back to my UW days, struggles with how to classify that. When undeniably it prolongs the OR time, undeniably it increases resource utilization, and without a question, there is a unfortunately small subset of patients, as you'll address in your talk that we're looking forward to, that requires substantial, possibly even life-threatening interventions. So it's not a benign thing to have a CSF leak, and certainly a neglected CSF leak. Two very famous celebrity cases come to mind here. I'm not going to dwell on their names right now, but so why is it not a complication? I'll just ask facetiously.
Yeah, no, actually, it's not a facetious question at all. I think it's a very legitimate question. I think on the one hand, we may overwhelm the cyst by reporting all of them. And it goes without saying exactly what you indicated, which is that it does increase OR length of time. And even with early mobilization, it does prolong hospitalization even by a few hours. If we're on the ERAS protocol, a durotomy would definitely make us keep the patient at least overnight. And so it is, an unintended, there are unintended consequences that happen as a result of a durotomy. And I do find merit in reporting them through the QA process. If we did take the patient back to the OR, obviously for a repair, that goes, that's a very clear cut. I just think with a durotomy, historically, we haven't reported it, but, we could at least keep track of it and see what are the risk factors for it. I know there's a lot of AI algorithms and trying to figure out, who are at risk for developing durotomies intraoperatively, or if the surgeon had a durotomy from the operative note, is it possible to pick this up? So I think there's techniques that are coming out that we could study this in a better big data type of fashion. But, just historically, as an institution, we haven't reported it.
Fair enough. And again, I just want to point out there is no right or wrong answer. This is always a great discussion point, and we're so grateful that you're willing to talk about Dura and CSF today and adverse things. I'll address the next question to you and to Zorica as basic scientists. If you put your hat on in terms of cellular physiology, what's the best autologous graft material and why? You mentioned fascia. Again, I was brought up in the fat vein, and a lot of people put muscle graft on there. If you can't get a water seal repair, what are your thoughts as to what the ideal autologous material is and why? Do you want to go first, Ganesh, or do you want to go first, Zorica?
Oh, yeah, sure. I think the choice of the autologous graft really depends on the size of the breach. If it's a small breach, I think it certainly is worth trying to get fat and then getting that to somehow cork in, or at least provide some kind of back pressure on the repair. That I would say is my first autologous graft choice. And if the defect is bigger, then I would say a fascial harvest, so that it can actually seal back with the native dura. But I think it really hinges on the type of the size of the breach. In the past I have also used muscle, but I find that muscle is a bit too stiff and can actually get smaller as it dries out, and we can actually lose the secondary repair from a muscle repair. So I've tended away from muscle as a choice. So it's either fat for smaller breaches or autologous fascia for larger breaches.
I would agree with Ganesh, exactly. It really, it's the size, location, and then the same order of autologous. And I know that that also primary closure has been used in combination with graft material if it's a larger breach. And then, as it's been mentioned, people go to non-autologous like fibrin and collagens. but I would leave muscle last, biomechanically and also from the biological standpoint.
So, and one more question about sealants. So, Ganesh, you said you're using fibrin glue. Our old friend, and he's a neurosurgeon, just so you know, at Ken Yanamura, a very busy spine surgeon. He again texted me and he said he's just not used sealants anymore. It made no sense based on fluid dynamics, and he uses Duraseal, basically a product name here. So first of all, what do these membranes, these biomembranes that Abe presented, actually do? Do they actually interact with the dura and induce fibrocyte growth, or what kind of tissue interactions are there of these, quote, biomembranes? Can either of you address that and then comment on the other? Ganesh, do you want to take it first? Biomembranes.
Sure, yeah, I can't speak on the membranes. The reason I use a sealant, whether it's to seal, and I haven't used Duraseal recently because of what was brought up in the last presentation, which is that I believe Duraseal is more prone to an increase it can swell to twice its size, and we've seen that on postoperative imaging. But my main reason for using some kind of fibrin glue is basically akin to the concept of blood patches, that it just creates a barrier so that if we do end up using a subfascial drain, there's just one more layer for that would be between the subarachnoid space and then the subfascial space. But I'd be very curious to hear, it sounds like Dr. Özgüryan does not use fibrin glue, and I'd be curious to hear his thoughts as well on this.
Rod, you're not using glue, and Abe gave you the nod. Yeah. He says glue is not necessary.
I mean, honestly, I think, I've tried them all. I think my feeling about, whether it's fibrin seal or Duraseal, when I've gone back in, I've had a couple cases where, you go back in early and you kind of can see how the sealant works. And I'll be honest, I wasn't impressed. Like the one case I went back in, the sealant was just like floating in the wound. And then the other time I went back in, it was like 2 weeks post-op, and it was like not even there. It was just like it had melted. And in cases, and I just go back to I spent a year in New Zealand, and there one of the surgeons used Surgisil for everything. And that's kind of what I went back to, is getting a good primary closure and using, basically Surgisil, and it kind of forms this, I think it attracts a little bit of more blood, and I just feel like it gets a better seal. So that's kind of what I've kind of gone full circle.
So as a basic tissue PhD, Zorica, should we put this glue on? Does this help, or is this just another foreign body that's floating around in isolation?
It does. So fibrin sealant's been used in spine, and obviously there are no cells, so it relies on growth factors that are present that could potentially promote fibroblast growth and collagen deposition. So people believe that it can serve as a patch, and it can have some additional biological advantages. And then there are other patches, as you mentioned previously, amnion, that obviously we don't have that much evidence, that do have cells as well, and that could provide additional, would have an additional role than just a barrier or a patch.
So let's look at the ultimate bio-sealant. Dr. Glenn Davis, our Chief of Interventional Spine Care, and he's a phenomenal practitioner. He's helped me out a couple of years ago with a patient where I did a decompression, and 2 days later the patient had headaches, no drainage, and he helped me with a, quote, blood patch. So what is a blood patch? How many cc's do you put in a contained, sealed lumbar incision? Let's say 2-level decompression.
Sure. Yeah, we use this intermittently to help. You hear me now? We use it intermittently to help with CSF leaks when asked by the surgical team. We use it using the patient's about 10 cc's of the patient's blood, injected into the epidural space at the level where the CSF leak is, and had some success with that, as you guys have seen over the years, in helping to seal that leak. About 10 cc's of the patient's blood and into the epidural space. So we're using loss of resistance into the epidural space to get into the area.
So that's the ultimate bioglue. Let's look at another case with a difficult CSF leak, and we'll have to do this in about 5 minutes because I want to have 10 minutes for Amanda's case. Is that okay, Chris?
Yeah, I'll
So
go
Chris
fast.
Seidel is one of our, again, Pennsylvania refugees, and I wonder why. And no comment. No further comment, Chris. And he was so kind to look up at a different case, and then Amanda is going to close with a highly complex case. So it's getting better, Ganesh.
All right, so this case is a 48-year-old woman. She had 6 months of progressive symptoms: bilateral hand weakness, clumsiness, severe right upper extremity pain. She was unable to really move her neck much, secondary to pain. She was seen in the ED multiple times for this problem before she came to us. Smoker, morbidly obese with a BMI of 43, sleep apnea, anxiety, depression. On exam, she had some weakness in bilateral intrinsics, some non-dermatomal dysesthesia, no abnormal reflexes though, severe pain with any range of motion of her neck. On FlexX films here, you can see that she has very little motion that she's able to show secondary to her pain. So on MRI, she has spondylosis C5-6, C6, C7, large herniated disc there at the C6, C7 level. You can appreciate that on the axial as it's getting down right there. It is not calcified, as you'll see on the CT.
So large, two-level soft disc, very large with neurology, no myelopathy, right?
Correct.
All right.
So she came to clinic, and due to her severe pain, she was admitted for surgery. However, at the time of intubation, she became acutely hypoxic. So surgery had to be canceled at that time. Chest imaging showed that she had significant atelectasis, and it was presumed that it was from spending significant amount of time recumbent because she was unable to tolerate being upright or moving her neck very much. So she got tuned up. Pulmonology saw her. She was eventually cleared for surgery medically, and she went to the OR 8 days later for her ACDF. So you can see well-positioned instrumentation. But during the 5/6 discectomy, there was a right-sided root sleeve durotomy at C6. There was immediate CSF blush. There was no EMG discharge at the time. A cottonoid was placed and the fluid leak was controlled. The tear was then covered with Dural and a fat graft, and that was kind of placed into the foramen and packed with a little bit of compression. And then there was Dural and Surgicel layered on top of that. A Valsalva was performed, showing no additional leak, and a subfascial drain was placed at the time of closure. So she went to the ICU and remained intubated for 3 days. She did well, was extubated, transferred to the floor. Motor and sensation were fine. Right upper extremity symptoms were completely resolved. She did have frontal headaches for the rest of her admission that slowly improved. Repeat head CT showed no loss of CSF. Her NG2 for her dysphagia came out at post-op day 6 and discharged on day 10. 6-month follow-up, she was reporting that she was very happy. Her paralyzing pain symptoms had completely resolved, and she wasn't taking any more pain medication at that time. I did find one study that was from World Neurosurgery 2016 that talked about their own problems with CSF leaks in anterior cervical procedures. Specifically, they had a cohort of 8 patients, and they were all treated exactly the same way, and they talked about the results based on that treatment. So it was basically the same thing that was done here. A cottonoid was placed, very low suction to kind of decompress the pressure. They placed a dural substitute of some sort, and then a dural sealant over top of that. And then they placed a subfascial drain. That stayed in for about 2 days. Patients were allowed to be upright after about 3 to 4 hours and ambulate on post-op day 1. And they said they had no persistent CSF leaks, no complications related to it at 6 months, and their outcomes were basically the same as they had been for patients who did not have CSF leaks, improvement in NDIs and vasculars. They also did a literature review as part of this of other groups who reported on anterior cervical CSF leaks. And so what they found were the methods for treating CSF leaks included primary closure, if amenable, fibrin glue, gel foam, fat fascia or muscle graft, blood patch, lumbar drain, post-op bed positioning. So all things that we've mentioned already. And these are used in various combinations with various degrees of success. So takeaway message is that these are rare in the cervical spine, but they can be addressed intraoperatively using any combination of these methods and still have a successful outcome.
So thank you for a very nice presentation that glossed over the fact that there was a lot of drama involved.
Yeah.
If you go back to my postoperative CT scan, this patient, despite a substantial body size, actually developed a very visible anterior neck swelling. And so Ganesh, first of all, hydraulics in the cervical spine are quite different from the lumbar spine. Do we put these patients at bed rest? Do you mobilize them aggressively? What do you do differently in an anterior CSF leak like what I had incurred, much to my frustration? Assume it's absolutely unrepairable.
Yeah, first of all, congratulations on getting the patient through this on both occasions. Sounds like a first very challenging attempt at even the intubation and then carrying forward to help this person out to a successful outcome. So congrats to the team. I think obviously this is a very unique case compared to thoracic or lumbar. In a case like this, I'd probably mobilize them in the way I would with a suboccipital craniotomy patient, where I would want to keep them upright to help the CSF drain down as opposed to flat and let the CSF pool in the neck. So I think mobilization and keeping them upright is a good thing in the cervical spine. The second part I'll say, and this actually will relate to one of the videos I'll show in my talk as well. One of the reasons these CSF leaks do ultimately resolve nicely is that unlike what we can achieve with a thoracic or lumbar decompression, but similar to what Dr. Chapman was asking about laying down bone graft, is that here you have a repair and you're buttressing that repair with a solid graft. So it's actually holding all that layering down over the repair of either the fat or the dural substitute or the fibrin glue, whatever you're using. You have the scaffold, whether it's titanium or it's the it looks like a BG2 allograft here. You have that holding the material in place, and I think that helps provide some back pressure and getting to a successful CSF leak repair ultimately.
I've actually revised some cases of other surgeons where they had plastic materials and as grafts and put biologic graft in there and then gently compressed it with biomaterials and got it to heal. So let's go for the last case, but there's so much more to talk about. Dr. Cecino has a very interesting case of Dr. Oskurian's, but we, by the way, tried to put a lumbar drain into this lady. The drama continued, and they could not put a lumbar drain into her. She just about aspirated in the procedure room and required, it was a nightmare, but that big goose egg that she had anteriorly in her neck actually vanished. Mark, I still don't know how that can be possible. So Dr. Amanda Cecino came to us from Johns Hopkins. She's done a great job and has done a great job with research also. And she has a very interesting case. We've shown it, apologies to some of you in the past, but now we have long-term follow-up. So Dr. Cecino.
Good morning. So our patient's a young female. She had presented to an outside ED with spontaneous onset of positional headaches, no other neurologic symptoms. She had no neurologic deficits on exam. She got an MRI of her brain, which found pachymeningeal enhancement and prominence of the pituitary gland, 2 signs concerning for intracranial hypotension. She was then transferred to us for further workup. So initially, she underwent a pan-spine MRI. The lumbar MRI showed bilateral cystic structures filled with CSF, spanning from about L5 to S2. And on the axial cuts, you can see at the level of the S1 nerve roots, which are the red dots, that the cysts are contiguous with the lining of the nerve roots. Whereas at S2, there is a distinction between the wall of the cyst and the nerve roots. So at this point, we have cystic structures associated with the S1 nerve roots that extend caudally and displace the S2 nerve roots. The patient then got a CT myelogram to look at CSF flow. Contrast was injected at L4-5, and there was clear flow throughout the thecal sac. There was contrast filling of the cystic structure on the right. However, there was no evidence of filling of the left cyst. The axial cut illustrates the proximity of the contrast filling into the S1 nerve roots, which are labeled by the red dots again. And at S12, you can see a fluid level, which provides more evidence that the contrast is pooling at the level of the S2 nerve root. You know, I think for me, the more interesting question is why did contrast fill the right cyst and not the left? And one explanation of the difference in flow would be a valve, specifically a one-way valve mechanism in the channel that connects the cyst to the CSF space overlying the nerve root. So CSF gets into the cyst, but it can't leave, and the cyst expands in size, and this fosters the creation of a Taroft cyst. As the next step of conservative measures, the patient was offered targeted blood patches. She had received 3 over the course of 2 months and did get a few days of relief after each one. And then following the 3rd patch, the patient still continued to be debilitated. And so we did offer her, surgical intervention, which I'll kind of just try to skim through here a little bit. So there you can see the bilateral Taroft cyst. We did lamies from the bottom of L5 to the top of S2. And then we're just kind of widening the space around to get a better look at the lamies. And then there we're peeling the Taroft cyst off of that S1 nerve root on the right. So that would kind of be the location of where that valve mechanism would be located. And then we're fenestrating that cyst. We took some of the cyst wall off. And then we made our way over to the left. And then after we did that fenestration, we used a proline to close down the cyst, basically at the opening of where it was associated with the S1 nerve root. We did about.
Was that hard to grab any purchase with the sutures there? This is very dysplastic dura, right? It's
Yeah.
very thin.
I don't think it was unexpectedly difficult. We knew what we were getting into.
But your sutures had a purchase in the
Yeah.
dura.
And then
Evidently.
we closed the left.
Wow.
And then we did a Valsalva. Everything looked good. And then we kind of just laid over Surgicel in the area.
Beautiful. No glue.
I think in this one, we didn't. Okay.
Dr. Escuin stuck to his guns. How'd the patient do?
So, did very well the first 2 months after surgery, was gradually returning to regular physical activities. She came in 3 months after surgery and she was complaining of some tingling on the top and back of her head, no regular headaches, which is what she had been experiencing, prior to surgery. So we recommended an MRI of her brain and L-spine, which I'll show next. She came back in for her 4-month visit and her tingling had improved and she's had full return now to her normal activities. So just very quickly, as I'd mentioned before, pituitary prominence on MRI is a sign of intracranial hypotension. And here you can see that she had decreased prominence at her MRI 4 months post-op. And then as well, increased pachymeningeal enhancement, which is another sign of intracranial hypotension, had decreased on her 4-month post-op. And, for this, instead of doing a video, I just decided to try to take the slice that had the starkest contrast. So on the MRI of her L-spine, there was only a small residual of the cyst associated with the left S1 nerve root. On the right, it's either re-expansion of the S1 cyst, or what I think it is there might be a new cyst coming off the S2 nerve root. It's causing some compression of the S2 nerve, but she's not symptomatic. So I think, in the future, if she does, become symptomatic, we could always just get another CT myelogram to take a look.
That's beautiful. Ganesh, we're ready for your talk, but I want to just invite you for some quick commentary. Taroft cysts are the bane of our experience. Amanda did a great job presenting that in visual detail. Any questions from you to Amanda, or comments, and as well to the surgeon, Dr. Skoyan, who did a beautiful job with this. This is, by the way, a high-performance athlete. We're obviously not identifying sport or whatever, but assume this is a professional high-end athlete.
I mean, it's what is there to say? It's such a beautiful case and very well executed. Amazing preoperative management with non-invasive or minimally invasive interventional techniques that were not successful, and then followed by a surgery with a video that demonstrates just excellent technique and repair, and the patient has done so beautifully. I mean, we shy away from the surgical management of Taroft cysts, but this case here really indicates how much of an impact one can have when managing these patients appropriately.
So CT myelogram, a very valuable tool then in your experience for these kind of hydraulically unstable or active lesions?
Absolutely. And I'll chat about that a little bit in my talk as well. So I think that's a perfect segue.
Well, Amanda, this is a great presentation, really nice before and after shots. So thanks for going through it again. We presented this a couple of months ago, and we just wanted to have the long-term follow-up. So it's really nice to see it. Any insights for your own practice? When do you act on a Taroft cyst patient as you're going to go into practice?
So I think what I've seen in the literature is about 16% of patients with Taroft cysts are symptomatic from them. And so I would say it really depends on the patient, depends on the type of symptoms as well. But I would be more conservative into jumping into surgical intervention. I think here she got, great conservative management ahead of time. And when she failed all of that, that's when we went to surgery, and she's been doing well ever since. So
great. Super. Thank you. Thank you to our fellows and all the chat room members. And I want to shout out to our colleagues in Libya and the Ukraine who've commented. And it's an honor to have you here. And also Dr. Tariq Sohail from Pakistan. Our guest speaker today is Professor Ganesh Shankar. He's an MD PhD at Mass General. He has won awards for his research and that goes into clinical and basic sciences with the AANS, the Congress, Joint Sections, and AO Spine North America, which is where I met him first. He's an excellent surgeon and investigator, and he treats multiple different spine pathologies, literally the whole gamut from oncology to routine degenerative things. And we asked him to talk about one of his special areas of expertise, and that is CSF, dura, and its interactions with the brain. And we're really looking forward to that, and we enjoyed your comments, Ganesh. So please educate us about interactions of CSF and intracranial pathologies relative to our practice as spine surgeons.
Wonderful. Well, thank you so much again for having me today. I remember being at your institute when I was a resident, and you were always so gracious in inviting us for these educational opportunities. And it's really a treat to be here now as a discussant. So thank you again for this opportunity, and very impressive display of cases over there as well. I just want to confirm that people can see my screen, my PowerPoint slide.
Yes.
Okay, great. All right. I'd like to get through this. These are my disclosures. I'd like to get through this discussion maybe in about 25 minutes so that we can leave some time at the end for questions. The topic that I will be discussing today is a bit different than some of the cases that we heard today, which is not necessarily either CSF leaks resulting from, at the time of surgery, incidental durotomies, or from trauma, or defects in skull bases, such as when a prolactinoma responds avidly to medical therapy, but rather spontaneous CSF leaks that occur along the spinal axis. And ultimately, that is a very similar clinical presentation of headaches, postural headaches, posterior neck discomfort, and other symptoms that can also masquerade together in this complex, including tinnitus, so always asking patients about a buzzing sound in the ear or a muffled hearing in one side, cognitive fog, dizziness, or as I said, muffled hearing. But these symptoms can be quite vague, and many of these patients who have had these chronic spontaneous intracranial hypotension symptoms get worked up for many other pathologies that can present similarly, including vascular dissection, sinusitis, meningitis, post-traumatic headaches, post-concussive symptoms, and also subarachnoid hemorrhage. And how do we sort this out? And we saw some of the key radiographic findings when patients have intracranial hypotension. Patients can manifest with either subdural collections, engorgement of the venous structures. There can be sagging of the brain, presenting almost like a Chiari malformation. The one that I really tend to follow as almost like a radiographic biomarker for whether a patient has intracranial hypotension and whether they have a response to the surgery that we performed is this right here, which we already heard about earlier today, which is enhancement of the pachymeninges. And that I find is a pretty robust indicator of response to surgical intervention. I wanted to look at the difference between radiographic manifestations of Chiari versus spontaneous intracranial hypotension. There are a couple different radiographic measures that can differentiate these two entities. So on the left is a Chiari malformation with a sagging of the cerebellar tonsils, which can look very similar to spontaneous intracranial hypotension. But radiographically, there might be some slight differences in the configuration of the third ventricle with relative to the tentorial incisura, or the pontomesencephalic angle, as seen in these measures right here, with decreases in both of those in spontaneous intracranial hypotension. But still, I tend to, instead of measuring these parameters, I really do tend towards looking at pachymeningeal enhancement as one of the more robust radiographic indicators. And so how can patients present with spontaneous intracranial hypotension when it's related to a leak occurring in the spinal axis? And the first question is there an epidural fluid collection? And if the answer is yes, the CSF could be leaking either through a dorsal end plate osteophyte, which would be a type 1 leak, or through a meningeal diverticulum that has ruptured along the axilla of the nerve, and then the CSF can find a path of egress into the epidural space through that, and that's a type 2 leak. Now, in type 2 leaks, it is definitely worth considering an epidural blood patch, and I'll show the data on that. If there is not an epidural, if there's no epidural fluid collection, it can be one of these two entities. The first, and I think this is there's an increasing appreciation for this type of CSF shunting, which is a CSF venous fistula, in which there is an abnormal connection between the venous drainage system and the paravertebral region and the nerve root sleeve. And this is a type 3 leak. This I haven't seen, but can occur, which is a tear in a non-traumatic setting, a tear that occurs distal to the epidural space and can result in CSF leaking out into the paravertebral region through the foramen. And in this case, we would not see an epidural CSF collection. What is the data for managing these types of leaks with an epidural blood patch? So type 1 leak, again, from a dorsal disc osteophyte complex that is puncturing the dura. In this study that was published in 2019, 4 of 15 patients were effectively treated with a blood patch. In patients with this type of leak, again, a type 2 leak with a meningeal diverticula, 3 of 4 patients were treated effectively with a blood patch. So I think depending on the type of leak that's present, one could certainly consider an epidural blood patch as a first pass. Type 3 leaks, which is the CSF venous fistula, none of those responded effectively to a epidural blood patch. Where do these occur? And this study here, I would say, mirrors my own experience in terms of where we find them most commonly. Type 1 leaks occur, as shown in the red dots, usually along the thoracic spine. Type 2 leaks usually occur off a large nerve root diverticula that often occurs in in the lower thoracic spine or the upper lumbar spine, and CSF venous fistulas occur usually along the thoracic spine, and I'll present a case that occurred at L1, L2. So just to show a couple examples of CSF leaks that occur from, again, type 1 leaks that occur from a disc osteophyte complex. Here you can see a digital subtraction myelogram. And I just want to highlight one thing which is really key in the evaluation and management of these patients. So this is really a relatively rare entity. I see probably a couple of these a month. It's by no means the lion's share of what I do on a daily basis in spine. And because they're rare, this really hinges on there being a very solid team effort between radiology, sometimes neurology, if they're also involved, neuro-ophthalmology, and then neurosurgery, orthopedic surgery. It's very key to have everyone on the same page. And so this really speaks to the initial evaluation and identification of the CSF leaks. The myelograms, whether it's a CT myelogram, a dynamic CT myelogram, or a digital subtraction myelogram, it really requires a lot of conversations with the radiologist and you as a surgeon to figure out exactly how to protocol that study to hone in on the regions of interest along the spinal canal. And this protocol, I would say, has really been born out of multiple conversations that we've had with Udo Scheivink, who's one of the known leaders in this field, and also Peter Krantz over at Duke in radiology. And so that's really helped develop the protocols that we have here at MGH in terms of how to evaluate and manage these patients. So type 1 leak, here's a case, a 33-year-old female who presents with 7 days of postural headaches with no trauma. Primarily, these headaches are occipital, but there is a holocephalic component. She has some photophobia, neurologically intact, but she's unable to sit up. This is her imaging, and we can see an epidural fluid collection along the ventral CSF epidural space in the cervical spine and a dorsal component along the thoracic spine. There was a disc osteophyte complex with extravasation of CSF in the ventral epidural space on this dynamic CT myelogram that was performed at T2, T3. And just to look at that disc osteophyte complex without the contrast, it's almost like a tooth that has developed in this relatively young female. So it's not really necessarily on the spectrum of traditional spondylotic changes that we see in the cervical spine or the thoracic spine, but these are unfortunate osteophytes that occur that I haven't fully understand why they happen in the first place, but it's a similar demographic of 30s to 40s in terms of age, and often in females more than males. The treatment options are possible blood patch, but as we know from the literature that for these type 1 leaks, there may be a low likelihood of success. There are anterior and posterior options to deal with this disc osteophyte complex. In this case, I'll present an anterior approach. We performed this with thoracic surgery to approach the T2, T3 disc osteophyte complex. Following the resection of the osteophyte, we packed the dural breach with fat and a Surgicel onlay with layering of fibrin glue. And the back pressure was then applied with a VG2 allograft, as can be seen on this X-ray. Now, this patient did very well, and she had resolution of her postural headaches. This was one of the earlier ones that I treated, and I was tempted to perform an anterior approach because of the relative location of T2, T3 in this patient to the sternal notch. We didn't actually need to create a sternal window, but unfortunately, what happened in this patient is that she did develop a unilateral vocal cord paresis and required a Restylane injection for a hoarse voice. And so with these low cervical upper thoracic exposures, that's a known complication, known risk. And so to mitigate that risk, I decided from then on to really try to approach these from a posterior approach, even in the upper thoracic spine. And so I'd like to show a second case of a very similar type 1 leak, but occurring lower in the thoracic spine. This is a 37-year-old female with 2 months of postural headaches, presented in July 2021 with spine MRI notable for an epidural CSF collection. She underwent a blood patch with 2 weeks of relief and then subsequent return of symptoms. And again, we see a very similar pattern of ventral epidural CSF collection in the cervical spine with a dorsal CSF collection in the thoracic spine. There were 2 putative candidates in terms of disc osteophytes. One was at T1, T2 with this sharp tooth-like appearance, as well as at T10, T11. But a dynamic CT myelogram resolved that the earliest contrast extravasation was occurring in T10, T11. And so again, we discussed whether it's worth performing another blood patch, but since she only had temporary relief and was quite miserable, we elected for operative intervention, this time with a posterior approach with neuromonitoring. And as you'll see in the video that I'll present, to approach these from a posterior approach, we open the dura on the dorsal surface. We rotate the spinal cord after sectioning the dentate ligament to visualize the ventral dural breach. The osteophyte is resected, and then the dura is repaired with a 6-O-proline. This is a review from Wouter-Scheibing's paper that was recently published in the New England Journal detailing some of these CSF leaks. And this is exactly what we saw in the operating room as well in terms of ventral dural breach from one of these osteophytes. So here's a video from that patient. Here we first identified that osteophyte. It does look like a relatively sharp tooth. That osteophyte is removed, and then I explore underneath the ventral dura. You can see the dentate ligament has a proline, and you rotated the spinal cord out of the way. But exploring that space to make sure that we haven't missed any other pathology, because really these are cases where we don't want to have to go back in. We want to be as definitive as possible. To repair the leak, I use a 6-O-proline I put a pair of these in a horizontal mattress fashion with a BV1 needle that allows me to curve the needle away from the cord. So I'm never suturing towards the cord, but away from the cord. Repair the dura, the dural breach with tying that off, and then here close the dorsal dura, the midline dural opening that we make to approach this, and there's some fibrin glue on top of Surgicel. And so this is the final repair, and this patient did very well with resolution of her postoperative headaches. Here's an example of a type 2 leak. Again, this is a leak that occurs from a meningeal diverticula, as Dr. Chapman had asked in that Tarlov cyst repair, and had pointed out that the dura surrounding the meningeal diverticula can be very tenuous and can be very challenging to get a good primary repair. So I'll show you how we deal with those here. 28-year-old female presenting with 2 months of postural headaches and fullness in her right ear. She also has a ventral epidural collection in the cervical spine and the dorsal thoracic spine. She has the canonical findings of diffuse pachymeningeal enhancement. She also has enlargement of the pituitary, as well as expansion of the transverse sinuses. And what her dynamic CT myelogram demonstrated was the presence of a pretty significant and a fast flowing contrast extravasation from the meningeal diverticula at the left T8 nerve root takeoff. And you can see that she had multiple diverticula up along the thoracic spine, but this was the ultimate culprit. This is how those diverticula can look. Again, this is from Dr. Scheibing's review in the New England Journal. This was the way we treated her pathology, which is we performed a T8, T9 laminectomy for visualization of the perineural cyst or the diverticula along the T8 axilla. We confirmed that that is indeed the site of CSF egress with a Valsalva. The dural margins were insufficient to repair the leak primarily, and therefore the nerve root was ligated with an aneurysm clip. And then, so you can see the aneurysm clip right here on the side, on the lateral view from the thoracic x-ray. And then I do put the bone back on the lamina with titanium laminoplasty plates as well. And so here's a video from a different patient that highlights how we do this. So this is a patient where we can identify the egress of CSF resulting from this perineural cyst or the meningeal diverticula that's in the axilla of the exiting nerve root here. We select an appropriately sized and shaped aneurysm clip. And with neuromonitoring, we encompass both the nerve root and the diverticula just adjacent to the lateral margin of the thecal sac to ensure that we have adequately encompassed the entire pathology. And then we can see that there is really no additional CSF that is leaving from that space. And then we confirm with neuromonitoring that there's no changes in the motor evoked potentials. Postoperatively, and this is actually important in terms of counseling patients preoperatively of what to expect, because especially for patients who have had these leaks that have been ongoing for some time, the CSF production may have been ramped up in that patient over months, years, however long this has been going on, to account for the fact that there is ongoing CSF drainage. And so what she had immediately post-operatively is almost like a mirror image of the headache, in that she felt better standing up and worse laying down, whereas preoperatively it was the opposite, with the postural component being worse when she was standing up. And so there was concern for now intracranial hypertension. And so we followed her very closely with imaging, and we did not detect the presence of hydrocephalus or any changes in the ventricular size. But the concerns in cases like this, where a patient may have changed their CSF production to account for this ongoing CSF leak, and then we abruptly stop that CSF egress, is that the CSF may continue to accumulate in that space. And so the plans B and C would be to maybe try some Diamox for a short period of time, or to consider the patient ultimately for CSF diversion with a shunt. Fortunately, she never needed any of that. She was able to manage her headaches, and then they ultimately resolved by about 3 to 4 months, but definitely it took time for those headaches, those mirror image headaches, to resolve. And we also confirmed that she did not develop intracranial hypertension by having her see neuro-ophthalmology to evaluate for papilledema. I wanted to discuss briefly the concept of CSF venous fistulas. This is again there's increasing appreciation of these types of leaks, where on dynamic CT myelogram we can see that there is contrast extravasation from the subdural space into the venous plexus through the foramen. So this is a 66-year-old retired dentist with 1.5 years of subdural hygromas that started after a motor vehicle collision that he had 6 months prior to that presentation of subdural hygromas. And so his symptoms were orthostatic headaches, altered mental status. This is a previously very high-functioning gentleman who really presented with almost a constellation of findings that were similar to normal pressure hydrocephalus with cognitive decline, impaired gait, and urinary incontinence. And that's probably a separate discussion offline in terms of why there may be similar overlap here. This patient presented with some of the classical symptoms of CSF, of spontaneous intracranial hypotension with an orthostatic headache, and then also demonstration of an active CSF fluid leak. Here are the hygromas that he presented with. We also saw that he had some brain sag with descent of the cerebellar tonsils, as well as decrease in the prepontine space between the pons and the clivus. There was a possible CSF leak consideration from a T3, T4 spicule, but this patient did not have an epidural CSF collection, so we knew it was not a type 1 or type 2 leak. But what he did have are numerous thoracic and upper lumbar diverticula. And so he had a workup with both a dynamic CT myelogram as well as a digital subtraction myelogram, which are important for these potentially fast leaks. And what was noted is that he had egress of contrast from the axilla of the L1 nerve root through venous plexus that was then confirmed on a digital subtraction myelogram, very faint wisp. And you can see why this requires very close collaboration with radiology to protocol these appropriately. And this could be confirmed on an appropriately positioned decubitus CT myelogram as well. And so I just want to jump to number one, what are the management strategies? There are transvenous selective catheterization. It's a technique that's been proposed I believe at Mayo. We don't have that capability here, so it left us with surgical management. And so what I had done in this case is full exposure of the exiting L1 nerve root with a clip placement across the CSF venous fistula that can be seen with this yellow arrow. This is what the final construct looks like. And here is a video just demonstrating that there are these dense venous adhesions to the L1 nerve root from the venous plexus. And then following this case, the patient had resolution of his hygromas, as well as changes in the prepontine parameters in terms of increasing space. And then his subdural hygromas were completely gone by postoperative day 52. And he actually basically all those symptoms that he had of NPH had fully resolved as well. This is the last case that I'll present, which is a 50-year-old male presenting with 3 months of positional headaches and cognitive fog. And so there was suspicion on a digital subtraction myelogram that there was extravasation of contrast through the T4, T5 foramen into the venous plexus. And this is what our intraoperative findings were when we had performed a full facet resection at T4, T5. Here's the nerve root, and then a rich venous plexus that attached right into the axilla of that nerve root. Because this is a nerve root that had lower suspicion for being eloquent or at least functional, in this case, we clipped the nerve root completely to prevent any contrast extravasation or CSF egress into that venous plexus surrounding the nerve root. The patient did very well postoperatively as well, but also had those mirror image headaches because he had had these symptoms for quite some time. So the take-home points, I know a lot of text on this. I've underlined some of the key points here. Patients presenting with spontaneous intracranial hypotension can manifest as postural headaches, cognitive dysfunction, or other neurologic symptoms. The key intracranial radiographic stigmata are pachymeningeal enhancement, as well as other findings that we discussed. CSF shunting along the spinal axis can really starts with an understanding of, is there a epidural collection or not? And if there is an epidural collection, consider a type 1 leak with a disc osteophyte or a type 2 leak with a meningeal diverticula. If there is no CSF in the epidural space, then consider some form of a CSF venous fistula. High flow CSF shunting may not be captured on just a CT myelogram, so it may require some form of a dynamic CT myelogram or a digital subtraction myelogram, and that really requires a lot of collaboration together with your radiologists and interventionalists. And while an epidural blood patch or fibrin glue may be good for type 2 leaks with a meningeal diverticula, it may not actually work for some of these other leaks that are resulting from some kind of disc osteophyte that is stenting the dura open or a CSF venous fistula. The surgical options are directed towards definitive visualization and obliteration of the structural etiology. As I showed, it's either just completely taking out the facet to visualize the entirety of that nerve root and the associated venous plexus. It could require completely obliterating the nerve root that's associated with the meningeal diverticula. And then it's important to also just be aware and also possibly preoperatively counsel patients that there may be mirror image or high pressure headaches after a definitive closure, which are in our experience self-limiting and requires very close follow-up with the patients. And just personally, I feel that those mirror image headaches and the probability of those occurring or the length of time that patients may have them is related to the length of time of the preoperative symptoms. And then I just want to put my email address because, this is, I would say, a developing field. And if anyone is interested in emailing me either with questions or cases that we can discuss, I'd be happy to be involved in those discussions.
Wow, Ganesh, thank you. And thank you for being so generous, not just with your time and expertise, but also sharing your email on this, as you correctly said, evolving field. I have a few questions in my my chat box. Very basic. How much CSF, what's the range of normal CSF production in a regular healthy human being per day?
Yeah, I usually tell people that they generate about 2 cans of soda per day. So about 500 cc's. And so, and the vault contains about 125. So there's a constant cycling of about 4 of those volumes in a daily basis. And if there's, let's say, just even an additional 10%, or in the CSF venous fistula, it's incalculable how much CSF is going through the venous plexus, especially in those high flow leaks. That can go up to 10% or even doubling in terms of how much CSF is trying to be produced by the choroid plexus to keep up with that new demand.
Second question, dynamic CT myelogram. Please explain what that is.
Sure. So yeah, thank you for that question. So the dynamic CT myelogram, as opposed to a CT myelogram. So CT myelogram, contrast is injected into the intrathecal space, and then there's one image that's obtained. If there's a leak that is too fast, by the time the one image is obtained, the contrast may already be in the entire epidural space, and it'll be very difficult to pinpoint exactly where the leak is happening. A dynamic CT myelogram, on the other hand, the contrast is administered, and maybe the patient is placed in certain positions, like a decubitus position or a prone position or a supine position, to really try to maximize the chances of capturing the CSF leak in its action, which may requiring multiple images in a serial fashion. So it's not one image, but it's multiple and often rapidly obtained sequences. And so for that, it's really important to have the latest up-to-date CT imaging system to be able to capture those quickly enough with high enough resolution.
I was taught, expanding on that, to get delayed CT myelograms in certain question patients, like hydraulically active or hydrodynamically active valve effect CSF leaks. Is that still relevant, like a 2 or 3 hour delay CT myelogram? Is that an anachronism, or do you still see a role for that?
No, definitely a role. There sometimes, for whatever reason, the CT myelogram may not pick it up even the dynamic CT myelogram may not pick up a leak, or even the contrast extravasation into the epidural space. And so there are instances in which we will have the patient come back in about 2 to 3 hours for a repeat image to see if we can capture it. But unfortunately, by that time, the contrast may be too diffuse and may not be as high quality as the initial bolus that's administered.
Great points. Dr. Tariq Sohail from Lahore has his hand raised. Tariq, good to see you again.
Thank you very much, Jens, and thank you, Ganesh, for very interesting presentation. It's something totally new to us orthopods. Is there a relationship with this OPLL with extradural leak? Because of some of the OPLL, mass is very spiky in its nature. If you look at the CT scan, they are fairly sort of spiky, and they're likely to cause erosion and cause extradural CSF collection. And if it's there, how do you, identify and handle them? Thank you.
Yeah, that's great. It might all be, I have to say that, except that there might all be on some kind of continuum of these types of sharp disc osteophytes all the way up to OPLL. But the one difference here, I would say, is that when these type 1 leaks occur, they're really sharp, and they occur oftentimes from the disc itself, as opposed to the posterior longitudinal ligament. They don't always occur at motion segments, as we saw. They can occur in the thoracic spine as well. But I don't, at least in the cases that we've done of type 1 leaks, we haven't seen an overlap of the type 1 disc osteophyte complex that's sharp and erodes into the dura and OPLL. And like I said, oftentimes these are cases that occur in the 20s, 30s, 40s, prior to the demographic that normally presents with full-on OPLL.
Thank you.
Great question, Tariq. And again, good to see you. So the final question for me, and then we have to kind of move on with the clinical days. This was just spectacular, great lecture and materials and insights. And as you said, an evolving field. How often do patients with certain diseases like Taroft cysts or some of those type 3 and 4 diseases have collagen diseases like Ehlers-Danlos, Marfan's, etc.? And how does that influence your treatment?
Yeah, I'd have to look, I'll be honest, I have to look into that a little bit more, at least on the literature. I would not say that anecdotally, my own level 4 impression is that there isn't an overlap between collagen vascular disorders and like Ehlers-Danlos and the development of these leaks. So I don't know the answer to that, but I'll look into it.
No, because one case that we showed had a significant collagen disorder, and clearly that made the structural integrity of the dura far more problematic. So
Yeah.
Well, we really enjoyed this. I hope this will be an ongoing interaction with you. Really appreciate your educational efforts and your sage advice, and you clearly have immediately assumed a leadership role in this field for all of us. Rod, any final closing statements for Ganesh?
That was great, Ganesh. To me, what's interesting, I think you highlighted it, is just all the neuroimaging. What do you look at? Do you look at, the pituitary gland? Do you look at, the like there's so many different things you can look at. And I like the angle concept that you brought up. And I think that's another valuable tool. But it's one of these things like you pointed out. I mean, it's very rare, but when you do get these patients, it's devastating, and you can really help them if you try to figure out. I think localizing the area too can be sometimes difficult.
Yeah, dynamic CT mammogram,
Yeah.
definitely.
Yeah.
That's a major learning point for me. And I loved your summary slide. And again, your willingness of interacting with us directly is so appreciated. So quick self-advertisements. Again, we have December 2nd, 3rd, the 8th annual spine trauma course. You'll not be disappointed. Please participate. It's an all-star group of people who are very interactive, like Dr. Shankar this morning. And on December 10th, we have our robotics course. And prior to that, we have on December 7th, Nuj Kazemi from the University of Arkansas, a neurosurgical colleague, will talk about prone lateral simultaneous surgery using a robotic device. So cool topics coming up, a lot of learning opportunities. December 2nd, 3rd, trauma. December 7th, prone lateral robotic surgery. And then the big robotics course with our friends from Cedars on December 10th.